presentation will demonstrate major features of the internal cranium in relation to vascular structures. The calvarium, or vault of the skull, can be removed for study of the internal features of the cranium. This calvarium consists of the domed part of the frontal bone anteriorly and most of the parietal bones posteriorly. Some of the superior part of the occipital bone may be included. The floor of the cranium is formed by three cranial fossae: the anterior, middle, and posterior. Here the anterior fossa is shown in green, the middle in red, and the posterior in blue, while the lines of demarcation are left uncolored. The anterior and middle fossae are separated by the chiasmatic groove medially and by the sharp border of the lesser wing of the sphenoid laterally. The middle and posterior fossae are separated by the dorsum celli of the sphenoid medially and by the superior border of the petrous bar of the temporal bone laterally. The major feature of the anterior fossa related to vascular structures is the cribriform plate of the ethmoid bone. It has a vertical spine, or crista galli, which is separated from a similar crest on the frontal bone anteriorly by the foramen cecum. Major features of the middle fossa are the median sella turcica, and on each side, the optic foramen, superior orbital fissure, foramen lacerum, and foramen spinosum. All of these are in the sphenoid bone. The sella turcica has a central hypophyseal fossa that houses the hypophysis, or pituitary gland. Anterior to this fossa is an eminence, the tuberculum celli, and posterior to it is a raised plate of bone, the dorsum celli. This complex resembles a Turkish sow, hence the name sella turcica. Lateral to the tuberculum are the anterior clinoid processes, formed by medial projections of the lesser wings of the sphenoid. Posteriorly, the lateral angles of the dorsum celli form the posterior clinoid processes. On the lateral aspects of the sella turcica are shallow carotid grooves. These run from the foramen lacerum to the medial side of the anterior clinoid processes. The foramen lacerum is an opening of irregular size and shape. Its floor is filled by fibrocartilage in life so that it is not a true foramen. Just lateral to it is the small foramen spinosum, with branching grooves running from it. Anteromedial to the anterior clinoid processes are the optic foramina, and inferolaterally the superior orbital fissures. The most conspicuous feature of the posterior cranial fossa is the foramen magnum. Between this and the petrous bars on each side is the large jugular foramen, and on the posterior aspect of the bars is the internal auditory meatus. From the foramen magnum in the midline, an occipital crest runs up and back to the internal occipital protuberance. A groove runs laterally from this on each side across the occipital and parietal bones to the asterion, or junction of the occipital, parietal, and temporal bones. Here the transverse groove becomes sigmoid and turns down to run against the base of the petrous bar and turns again to end at the jugular foramen, formed by a notch in the occipital and temporal bones. Passing superiorly from the internal occipital protuberance in the midline is the sagittal groove, which is continued on the internal aspect of the calvarium to the frontal crest anteriorly. The cranial cavity is lined by the dura mater, which has an outer periosteal layer attached to the bones and an inner meningeal layer. These are closely applied to each other except where separated by venous sinuses and where the meningeal layer projects internally between parts of the brain such as the falx cerebelli, tentorium cerebelli, and falx cerebri. The falx cerebelli is attached to the occipital crest in the midline and projects between the cerebellar hemispheres. The tentorium cerebelli is a horizontal shelf of dura in the posterior fossa that separates the cerebellum below from the cerebrum above. It is attached laterally along the transverse grooves, but at their junction with the sigmoid grooves follows the superior border of the petrous bar to the posterior and anterior clinoid processes. This attachment leaves a gap, the incisura tentorii, between the free anterior borders of the tentorium for the brainstem to pass forward at the level of the midbrain and cerebral peduncles. The falx cerebri is a vertical partition that extends between the cerebral hemispheres. Its anterior part has an inferior border that is free, but the posterior part is attached to the superior aspect of the tentorium cerebelli in the midline. The superior border is attached along the sagittal groove of the vault of the cranium from the crista galli anteriorly to the internal occip protuberance posteriorly. The main venous drainage of the brain is via the internal jugular vein of the neck that commences at the jugular foramen. Minor drainage occurs via the pterygoid plexus of the infratemporal fossa, and potential drainage is available via emissary veins that connect through foramina with veins of the neck, face, and scalp. The main drainage is into the superior sagittal and straight sinuses. The superior sagittal sinus begins anteriorly at the foramen cecum and runs in the attachment of the falx cerebri at the vault to the internal occipital protuberance. It forms the sagittal groove that widens progressively and has lateral indentations formed by arachnoid granulations, which project into venous lacunae that drain into the sinus. At the internal occipital protuberance, the sinus bifurcates to form a right and a left transverse sinus that also leaves grooves. At the bifurcation, it is joined by the straight sinus that runs in the attachment of the falx cerebri to the tentorium cerebelli, and so leaves no bony marking. It is also joined by a small occipital sinus that runs in the attachment of the falx cerebelli to the occipital crest and leaves a groove also, passing up from the foramen magnum. The junction of the superior sagittal, straight, occipital, and transverse sinuses is called the confluence of sinuses, or torcular Hierapolis, which means the winepress of Hierapolis. It lies in the area of the internal occipital protuberance, which corresponds to the external occipital protuberance on the cranial surface, where posterior neck muscles give way to scalp. From the confluence, the transverse sinuses in their grooves run on each side in the attached margin of the tentorium cerebelli to the asterion. This sinus then leaves this attachment, curving medially as the sigmoid sinus, to run along the base of the petrous bar, and then turns into the jugular foramen anteriorly. This part of the sinus leaves an S-shaped groove. Note that the sigmoid sinus is in close relation to the mastoid air cells. Hence, mastoid infection may involve the sinus and cause thrombosis or meningitis. Also, in surgical removal of infected mastoid cells or mastoidectomy, the sinus may be penetrated. Note also that the transverse and sigmoid sinuses are often markedly asymmetrical, as indicated by their grooves. The right is usually the largest, but sometimes it is the left, or they may both be equal. This indicates that blood flow from the sagittal and straight sinuses may be unequally distributed at the confluence with a resulting dominant right or left internal jugular vein. The carotid groove on the lateral aspect of the sella turcica not only locates the internal carotid artery, but also the cavernous sinus surrounding it, and is a common site for an arteriovenous fistula between the two vessels. This sinus extends from the superior orbital fissure anteriorly, then passing over the foramen lacerum to the apex of the petrous bar posteriorly. It lies largely between the dural layers forming the attachment of the tentorium cerebelli to the clinoid processes. The superior aspect of the petrous bar shows a groove for the superior petrosal sinus that connects the cavernous sinus anteriorly with the junction of transverse and sigmoid sinuses posteriorly. The sinus lies within the attachment of the tentorium cerebelli to the petrous bar. A groove for the inferior petrosal sinus runs along the suture between the occipital and petrous bones from the cavernous sinus at the apex of the petrous bar to the jugular foramen, through which this sinus passes to join the beginning of the internal jugular vein. A small groove on the free border of the lesser wing of the sphenoid lodges the sphenoparietal sinus that drains into the anterior part of the cavernous sinus. Note that the cavernous sinus not only drains into the jugular system via the petrosal sinuses, but also has veins passing through the foramen ovale and foramen lacerum to the pterygoid plexus of the infratemporal fossa. The cavernous sinuses also communicate by intercavernous sinuses, anterior and posterior to the hypophyseal fossa. This fossa is also roofed in by meningeal dura. Emissary veins and their foramina tend to be very variable in size. The parietal foramina lie in each parietal bone posteriorly and close to the sagittal suture. Their veins connect those of the scalp to the superior sagittal sinus. The mastoid foramina occur in the temporo-occipital suture, just posterior to the middle of the mastoid process. Their veins connect the occipital or posterior auricular veins with the sigmoid sinus. The condyloid foramina occur in the condyloid fossa, just posterior to the occipital condyles. Their veins connect those of the neck to the sigmoid sinus. The unpaired foramen cecum lies between the crista galli and frontal crest and has emissaries connecting the superior sagittal sinus with veins of the nasal cavity. The superior and inferior ophthalmic veins collect blood from orbital structures and pass through the superior orbital fissure to join the cavernous sinus. These veins also communicate with the angular vein of the face on the medial side of the orbit, which also drains into the facial vein itself. Hence, minor infection of the upper face may cause thrombosis with retrograde flow into the cavernous sinus with serious consequences. The meninges are primarily supplied by the middle meningeal artery, which enters the cranium via the foramen spinosum. It divides into anterior and posterior divisions in the middle cranial fossa, which branch repeatedly and leave grooves on the floor, lateral walls, and vault of the cranium. Note that the arteries lie within the dural layers and are readily torn by a moderate blow on the head, with resultant dangerous arterial bleeding within the cranial cavity. The primary arterial supply of the brain is via the internal carotid and vertebral arteries. The internal carotid on each side enters the carotid canal on the inferior aspect of the petrous temporal bone, just anterior to the jugular foramen. Within the canal, it runs anteromedially for about 2 centimeters and then emerges in the middle cranial fossa at the anterior end of the petrous bar at a point over the floor of the foramen lacerum. The artery then passes anteriorly on the side of the sella turcica, forming the carotid groove and being surrounded by the cavernous sinus. It then turns medially under the anterior clinoid process and gives off the ophthalmic artery, which enters the orbit with the optic nerve via the optic foramen. The internal carotid then sends branches to the brain and anastomoses with the vessel of the other side. The vertebral artery on each side arises from its corresponding subclavian artery and ascends the neck in the foramina of the upper 6 cervical vertebrae. After emerging from the atlas, it turns medially over the vertebral arch, posterior to the articulation for the occipital condyles, and enters the foramen magnum posterolaterally. The right and left vertebral arteries join over the basal part of the occipital bone to form the basilar artery. Note the circle of Willis formed by the anastomosis between the basilar and the internal carotid artery.